So at this point, we'll go ahead and start with the anterior structures, and I'm going to palpate the retinaculum along the patella, and I examine the entire length of the patella, going down to the origin of the patellar tendon, and then palpating the patellar tendon itself down to its insertion onto the tibiotubercle. Did any of that bother you at all?
There might be a little soreness when you push down there.
When I push down on the patella. Okay, so again, palpate the patellar retinaculum, palpate the origin of the patellar tendon, palpate the patellar tendon itself, and then I palpate on its insertion here. Now I'm going to concentrate on his medial structures. I'm palpating the medial joint line. The way we find that is we go up from the tibial plateau, and there's a soft space in between the femur and the tibia, and that's his medial joint line. The first portion is called the anterior horn of the medial meniscus, and I palpate all along the length of that down, back to the posterior portion of the medial meniscus. Does any of that bother you?
No.
All right. Then what I'll do is I'll drop down into the pes anserine, which is the insertion of the sartorius, the gracilis, and the semitendinosus tendon, all on this common spot on the middle portion of the tibia. Any pain when I palpate the pes anserine?
No.
Then I palpate the medial collateral ligament, which is not a distinct structure, but I know it comes from the medial femoral condyle down to the medial portion of the tibia, and I palpate for any tenderness along there, any tenderness along the medial collateral ligament.
No.
Okay, and that would complete the medial portion of palpation. Then I'll palpate the lateral structures. I palpate the lateral joint line, very similar to the medial joint line, where I start with the anterior horn, palpating back. Right in the middle is this lateral collateral ligament, but I'm not concentrating on that. I'm concentrating on the posterior portion of the lateral joint line. Any pain with that at all? Now I'll go and palpate the lateral collateral ligament, which has a distinct structure from the lateral femoral condyle to the fibular head, and any tenderness on the lateral collateral ligament there.
Not really, no.
Okay, then the other structure I want to know is the iliotibial band, which inserts down here at Gertie's tubercle on the tibia. Any discomfort there?
No.
I'll go ahead and I'll palpate the medial hamstring muscles, which includes the semimembranosus, semitendinosus. Any tenderness there?
No.
I'll palpate the lateral hamstring, which is the bicep femoris. Any tenderness there? And then the final thing I'll do is I'll flex and extend his knee, feeling the iliotibial band sliding back and forth over the lateral femoral condyle. Any tenderness with that at all?
Not really, no.
And then the range of motion and strength that I'll test for is go ahead and straighten your knee out all the way, and then go ahead and bend it. And unfortunately, this isn't full flexion. This is 90 degrees. We'll test full flexion when we lay him on down there, but no tenderness when you fully extend that at all. And then I can test strength, and I'll ask him to kick me, and I'll ask him to pull back. When he kicks me, that is knee extension, and when he pulls back, that is knee flexion on there. Any tenderness when I do those?
No.
That would complete our palpation. I did not find any tenderness other than our patellar when I was compressing the patella. Is that correct? Can I have you lay down, please? At this portion, what I would do is a visual inspection to see if there's any swelling. Swelling will be, it may be very obvious, or what you may have is the normal concavities that you have will now become convex because they'll be pushed out with fluid. One of the other things that you can do is patellar blottment, where you push down the patella and it'll feel like it's floating on here. I don't see any signs of any swelling in his knee, and if there is a true knee effusion, that needs to be explained. So at this portion, I would go ahead and complete his patellar exam. And the first test that we would do is we would look for any patellar apprehension. The way to test for patellar apprehension is to displace the patella laterally. Again, almost all dislocations, subluxations are laterally, and you would injure the medial patellofemoral ligament. So the way to do a patellar apprehension is you push on the medial aspect of the patella, and you try to push that laterally. And the patient, if they have instability, will actually ask you to stop, or you'll feel it overtly sublux. Does that cause you any discomfort? While you're doing that, you've now displaced the lateral facet of the patella, and you can feel underneath the patellar facet for any pain underneath the patellar facet. Does that bother you at all? Yes. Okay. So again, to reiterate, I'm testing for apprehension by moving it, and then I'm also feeling underneath the lateral patellar facet. I will do the same thing medially, where I'll push on the lateral aspect of the patella, and I'll feel on the underside of the patella for the medial facet. Does that bother you at all? Yes. So you have discomfort underneath the patella on the medial aspect and the lateral aspect. Is that correct? Correct. Then I will do a patella compression where I push down on the patella. Be mindful to not push too much force because you could hurt anybody with that. Does that cause you discomfort here?
It does.
And we feel that that's the cartilage underneath the patella being compressed in the femoral trochlea, but that causes you discomfort. Next, I will do what's called a quad fixation test or a Clark's test, and what I'm doing is fixing the quadricep tendon. I'm going to ask the patient to flex his quadricep muscle, and that'll force the patella inside the femoral trochlea. Can you flex this quadricep muscle? Does that bother you?
Yes.
And again, don't use too much force on that. So you had pain with compression, you had pain when I palpated the facets, and you had pain with the quad activation. Is that correct? So that would complete my patellar exam. Then I'll move on to my ligamentous exams. The first ligamentous exam we would do would be the Lockman test. There are two variations for the Lockman's test. One is to hold the femur and fix it with your more superior hand, and then you're pulling up on the tibia, and you're looking for a firm endpoint. If you have smaller hands, such as I do, and you have a bigger patient, that may be difficult, and so then we would recommend something called the modified Lockman, where you can put a knee or a pillow underneath the hamstring that relaxes the hamstring quadricep muscles. Then you would fix the femur, and then you would push up on the tibia. And this is a gentle motion. It does not need to be a violent motion, and you're looking for a firm endpoint. A torn ACL would have a loose endpoint, and you would have increased displacement compared to the normal knee. Then to complete the test for the ACL, you would do an anterior and posterior drawer. When you do that, you actually sit on the foot, and you would put your hands on the tibial plateau, and you would pull forward and you would push back. Pull forward to test the anterior cruciate ligament, push back to test the posterior cruciate ligament. One of the other things I want you to get in the habit, though, is that if you have a posterior cruciate ligament, you may have a displacement, and so you're starting from already a posterior displaced, and it may confuse you. So make sure that both tibias are even. And in this patient, they're even, and so his anterior and posterior drawer were negative. So we just tested the anterior cruciate ligament, and we tested the posterior cruciate ligament, and then we could go ahead and test the medial collateral ligament and the lateral collateral ligament. The way to test the medial collateral ligament is about 20-30 degrees of flexion. You provide a valgus stress, and I'm trying to gap open the medial collateral ligament, and then you just do the opposite to test the lateral collateral ligament. So a variation to test the collateral ligaments is to use the bed as a fulcrum. And so to test the medial collateral ligament, 20-30 degrees of knee flexion, I provide a valgus stress, trying to stress the medial collateral ligament, and then I'll provide a varus stress, testing the lateral collateral ligament. And again, that's a variation to do the collateral ligament testing. So now we've completed our testing for our anterior cruciate ligament, our posterior cruciate ligament, our medial collateral ligament, our lateral collateral ligament. Next, we want to test our meniscus, and there are a few different tests for that. One test is called the McMurray test. You put your fingers on both the medial lateral joint line. You start an extension, and with the foot in neutral, and you fully flex the knee and bring it back to an extension. And then next, you'll externally rotate and fully flex the knee, and then fully extend it. And then finally, you'll go into internal rotation and fully flex the knee and extend it. And a variation of that is the meniscal grind test, where in about 20-30 degrees of flexion, you circumduct it with various loads of varus and valgus as you bring them into extension. And the whole concept of the meniscal test is trying to catch a piece of the meniscus or grind it and see if they have some discomfort in there. So that's a meniscal grind test and the McMurray test. And the final test for the meniscus is actually a standing test. If you can come up here for me and come on down. And the patient will assume 20-30 degrees on the test leg, so we'll test his right knee, and then just twist at the knee, please. And you ask him if there's any discomfort with that, and that's called a Thessley's test on there.